The overall aim of the program was to engage men as fathers to be involved in maternal, newborn, childcare, sexual and reproductive health, but also preventing violence. But for this 3 years pilot time, the main aim was not really to prevent violence, but violence prevention was part of the content of the program. The program was a weekly session program with men to go through this adapted module or curriculum that include different sessions, including the one around violence prevention, but also around SRIH, MCH, communication, and all those topics that were relevant to the context of Rwanda. And by talking about prevention of violence, it actually preventing all forms of violence. Because during the formative research, but also during the sessions themselves, it was clear that actually all those forms of violences were present in their relationships, being economical violence, physical violence, emotional violence. So it was actually dealing with all those forms of violence. First, being aware of what does it mean, because sometimes, given the context, the culture, the traditions, some practices that men were doing or some behaviors that they had that were really violent, for them, given the traditional norms, they could not tell that really this was violence. And this is one of the positive outcomes of this program, because men ended up understanding that actually that what they thought was normal as a man, as a real man in this community, was not really normal, it was violence. And then coming up with possible solutions on how to overcome that and to become less violent or practically actually address those violent behaviors. And this was possible because after adapting the program and developing the curriculum, we trained community members as facilitators to take through those participants for the curriculum, the implementation of the curriculum and the weekly sessions. Regarding the scale-up, as I said, we first had this first phase was the pilot phase between 2013 and 2015. That was really very successful, if I may say so, given the way men were taken through this process regarding their harmful behaviors and how to overcome those, and having some men participants sharing their experiences and testimonies on how the program have helped them to change or to promote positive masculinities and become more engaged, in participating more in those traditional female like chores or activities or tasks. We were able to conduct a randomized controlled trial to evaluate this program, which have shown also tangible evidence on how the project or the program was successful. The discussion started with the government to see how the program could be scaled up in other districts. Because again, to emphasize that the pilot phase was only in 4 districts in Rwanda out of 30, given the positive outcomes that is showing and the contribution to the government or the country's priorities around those topics and those issues. So then this was tested in 1 district, and this time around a bit differently, because during the pilot phase, the facilitators I mentioned who were trained on the manual in the program were just community members from the communities who have been implementing the program, just based on a given list of criteria. So then for the scale-up, for the sake of sustainability, also ownership, and also institutionalizing the program and making sure that actually the government is able to own the program. This is one of the strongest structures that exists in the community, going from the national level to the village level. We saw well-trained community health workers. So for the scale-up, first testing this in 1 district among the 4 districts from the pilot, but also testing through community health workers as an existing, a very strong structure that exists already. They are working on the communities. So it was like adding this new task to what they are doing. So it was very important to train them on this approach, the gender transformative approach, and the program itself, so that they could integrate this in what they already do in the villages and their communities. So to transition to the full scale-up then, community health workers were trained, we evaluated, and then we realized that actually it was possible that they could really, with a good training, support, good supervision. I would say that the key or the main lessons learned from this scale-up process, first of all, is the involvement of the government from the very beginning. Because, again, to say that from 2013, when the pilot started, we made sure that actually we are with the government throughout, for the formative research, for the training of the facilitators, for the training of the health facilities staff. So we've been with the government from the very beginning. This is one, as a lesson learned for the success of the scale-up. So secondly, is the fact that the program aligned very well with the government priorities. So they see that the program is contributing to achieve the government, vision and mission in this field. And I would say the training, good training of those who implemented the program, including the first phase of the pilot, the facilitators, and then when the scale-up started, the training of the community health workers, and all those who were responsible of doing supervision, providing technical assistance, and all that. They are really overwhelmed. Community health workers in Rwanda, given that this is one of the so well organized structures in the countries that work up to the village level. So there are so many partners, donors, and people who want to work with them to help implement their programs. So which means they have a lot to work on. So secondly, on the capacity, because most of the things that the community health workers work on are mostly related to health, and less on those gender transformative approaches program. This was quite new to them. Capacity was a bit low, which was another challenge. But again, as I said, we were able to overcome this with actually strong training to them. One challenge that came out from this scale-up through community health workers, and again, this is related to violence, is that actually some or many of those community health workers themselves were living in violence, I would say violent relationships, which was challenging for themselves. But again, we came up with a strategy to overcome this by inviting their partners to go through a training and supporting them, so at least they can start the work on themselves before going to support others. Is this kind of, stepping back a little bit and having the role of providing technical assistance and not really very much in the direct implementation. So which makes also a difference, and also which is a good thing actually to see that the communities, community health workers, Ministry of Health, and the whole health system is actually enough capable to implement or to deliver the program with less involvement of. A few tips for those who would need to scale up such programs. I think I already mentioned that. First of all is to make sure that you have the buy-in from the government. Because scaling up meaning institutionalizing, it meaning ownership, it means also financial means, because it requires also money. And this can only be possible if the government owns the program and the program is institutionalized in the existing structures. Make sure that actually what we are doing is contributing to the government priorities or programs, and make sure that actually the government supports the program. Secondly, capacity building training. Because if you're talking about scale-up or going successful scale-up, you have to make sure that those who are scaling up have enough competences, in terms of skills, knowledge, on how to scale up the approach. Training is really very important. Thank you.